It's my pleasure this morning to introduce Dr. Kondziolka, who is a professor of neurosurgery as well as radiation oncology at NYU. Dr. Kondziolka is a very prolific author and internationally renowned for his work in this area, and he's going to be talking to us today about stereotactic radiosurgery. So thank you very much for joining us.
Thanks, Kevin and Bill, Greg, Michael. It's a pleasure to be with you again. I think the last time we did this was maybe early in COVID or pre-COVID. I really can't remember, since COVID has that effect on a time warp. But I'm delighted to spend time with the excellence of the House Ear Institute and House Clinic. And what I'm wearing today, I wear it, you guys. I want to stand up a little bit. I hope you can see it, but I'm wearing my House Ear Institute Foundation T-shirt, and out of respect for your center, and kudos to the staff and Dr. Brackman, who sent me that a few months ago after I filled out all the forms, and I said, I hope I get a T-shirt. I want a T-shirt, and they sent me one, so that was good. So I want to start off. I'm going to take you a little tour of things. How radiosurgery sort of plays a role in decision-making around the CP angle. We'll show you some new things related to vestibular schwannomas. We'll talk about facial schwannomas, glomus tumors, a few other types of things that show up in our world. And I just wanted to show you this slide. This is a PhD thesis, which is very thick, like many PhD theses are. It's about this thick, as you can see. And this is from one of the fellows in neurosurgery in Marseille, working with my friend Jean Regie. I had the opportunity to be the thesis defense, one of the two defense people back in December. And this was really a deep dive into the literature. It's an amazing thing to read, that to my new fellows, I had to give them a copy. So it's great to see that young investigators are really looking into the questions that we all have. And of course, we always have more and more questions refining what we know. I mentioned earlier that there was a quadrennial vestibular schwannoma meeting that was hosted by the House Institute probably a little more than a decade ago, I think, in Los Angeles. The last one was a week or two ago in Bergen, Norway. And the prior one was at the Mayo Clinic. And you can see that from the proceedings of this conference, a number of projects arose, and here's one, including participants from House, and looking at the questions related to vestibular schwannoma care and trying to come up with a consensus approach using a Delphi analysis that lays out the questions. The panels decide what they think is acceptable or requires refinement, and it goes through multiple rounds. And this paper was published in 2020. I think it's a really great article. In fact, I give this frequently to patients because it lays out all the questions that they may want to answer and shows on the right, for example, the degree of consensus on certain questions and based upon the literature or people's opinions. Like everything that we do when we talk about tumors in particular, we have to have an understanding of the natural history. And the natural history of vestibular schwannomas continues to be refined. We might think we know this and we have it well sorted out, but of course, for many, many decades, the understanding was through linear measurements on sometimes good resolution scans, sometimes poor scans, especially in the old days. But now in an era of volumetrics, there's been a number of articles that come out. So I start with this, and this was a paper we published a couple of years ago, taking 200 patients who were observed for an average of about 2 years. And I show this to all my patients and tell them that about 30% of them didn't change much during this 2-year period. 70% did, and half of that group grew fast. They more than doubled in volume per year, and half of them grew at a slower pace, less than that. And it's very similar to a study that came out of Mayo on the same topic. But if we go back to what was sort of thought to be the case for vestibular schwannomas from institutions of high regard, growth was defined as leaving the auditory canal and now becoming extrameatal. Not that it was 2 millimeters bigger, but that it had to leave the auditory canal. And only 17% of intrameatal tumors grew, which didn't make any sense. And these findings justify primary observation of small tumors. And this paper that was published in Neurosurgery in 2015, looking at 10-year follow-up on growth rates for intracanalicular tumors, these are the comments being made. Tumor growth occurred in only a minority of patients, which is certainly not the experience of a lot of other centers in the world. And so volumetrics were the key. And of course, volumetrics are difficult. I'm going to show you some work where hopefully it'll be easy soon. But of course, right now, we're having to do these ourselves. It's not really automated, but you can see a tumor at this point, and 9 months later, it looks like this. You might say, well, it's maybe 2 millimeters bigger, 3 millimeters bigger, but from a volumetric perspective, this is more than tripled in size in 9 months. Here's one, for example, over the course of 8 months, where you can see it's enlarged, and that's the volumetric change, more than double in that period of time. Here's one that did not change, and it's over a period of many months and years, and you can see that the change was essentially nil over a 9-year period as well. So, these are sort of the dynamics, and of course, these plotted logarithmically, these are the fast-growing ones in purple, more than doubling per year. The slower-growing profile in red, a stable profile at least over 2 years, which was the average, and two cases in our series had regression. But you can see that over time, most of these got bigger, not all, but most of them got bigger. And that was coming to eventual treatment by 3 years of 70%. So that was in patients who chose to be observed, that's where they ended up. And from a logarithmic model, if you wanted to quote an average growth rate of vestibular schwannomas, I think a number to remember is 33% growth per year by volume. Now, I don't think it's wise to talk about an average growth rate because there are different populations, as we just mentioned. So that paper, together with work from Mayo, as well as Southwestern, led to this 3-center large study, now with almost 1,000 patients undergoing observation and volumetrics. And this was published in Neuro-Oncology last year. And it shows you that, again, by 5 years, only 24% had not shown a growth-free interval. So you look at it the other way, 75% or so had shown progressive growth, including these are tumors of all size. So the concept that these hardly ever grow or the intramedullary ones don't really grow doesn't really bear out when it comes to volumetric. This is not necessarily saying they should be treated, but we're just talking about growth rates. And if you look at the growth rate patterns, what happens, in the first year of growth, it sort of sets up future either stability or growth. Very few are remaining without growth in that time period. Now, of course, I mentioned there's always been this thing about, do tumors spontaneously regress? And this paper just came out recently. The corollary paper is being written now, which is on the fast growth population. But if you go back and read this one, again, looking at volumetric regression, 82 out of 952 patients showed some volumetric regression, even if there was some initial expansion. So again, this can be a dynamic process. And as I mentioned, we're now getting to the point of automatic segmentation of vestibular schwannomas. There's a company that sort of can do this. There's a bit of a software arms race to kind of get good at this, and we've been working on this as well. So that's just a little bit of the sort of the current data on vestibular schwannomas. And now when we come to making a decision on, care planning, we look at growth, obviously, and we want to stop it if it's growing. Patients love to see a tumor that's smaller. We want to eliminate open surgical risks, of course, or not expose them to infection, bleeding, if whatever. Maintain function. And it's interesting that facial nerve balance and hearing are the key things that we talk about. Other symptoms are really uncommon. And of course, we're always trying to improve symptoms, but we're not really that great at improving tinnitus. We're not that great at improving imbalance, which usually can improve with compensation. It's probably a natural improvement. And of course, the Holy Grail has been hearing preservation, and lots of exciting things are going on there, of course, in terms of cochlear implants, even in the setting of an irradiated tumor or resected or partly resected tumor. usually in patients who have some hearing loss in the contralateral ear, but even in patients who don't, sometimes they're interested in hearing augmentation at that level. So let's just talk a little bit about the influence of growth on symptoms. So one concept is, does growth lead to hearing loss, or can hearing loss occur spontaneously even without growth? And is it a biologic effect, a microcirculation effect, and causing ischemia to the cochlear nerve or other structures, a secretory effect of proteins into the cochlea? We really don't know, but there is some issue, and it's been raised whether secreted factors from human tumors can cause some degree of cochlear injury, like TNF-alpha. And I guess one question I might ask is, at a biologic level, is radiation, for example, halting the secretion of such factors? Is that why hearing might be preserved in some people, but not in others? I mean, we just don't know. I mean, right now we think of this at a simple level, saying, well, radiation scarred the tumor, and of course the nerve got scarred, and there's radiation to the cochlear hair cells, but that's as much as we can take it. But perhaps there's more going on biologically. We published this paper recently looking at hearing loss and volumetric growth rates in untreated tumors, because it leads to this question with observation. And of course, observation isn't doing nothing. It's doing whatever, it's allowing the patient to just let the tumor do whatever it's going to do. And is it better to leave it in and just keep hearing naturally? We hope so. Or is it better to treat it, prevent growth, and prevent hearing loss? So that's the issue. So we did a matched comparison of hearing outcomes treated with radiosurgery or observation. This comes out of the volumetric database and published last year. And what it really showed was that the hearing profiles for both groups were the same. So observation did not beat radiosurgery. Radiosurgery did not beat observation when it came. And these are matched patients, 58 in each group, matched for Class A hearing. So we sort of matched for the audiograms. You can see the average age of the patients was identical, and about 58, 60% were women. And this is the profiles versus observation versus radiosurgery for maintenance of Class A hearing over time. It's identical. So I think now, if you think you're keeping hearing by doing nothing, is that better? I'd say the answer is not necessarily. When we just matched it for any kind of serviceable hearing, we now have about 100 patients in each group, again, well matched. And this is the cohorts and hearing data over time, observation versus radiosurgery, again, quite similar. So it allows us to talk to the patients about what their personal goals are, when they might want to intervene. Here's a 50-year-old woman who has a growing tumor, mean cochlea dose over here, 3.8 gray. We try to stay below about 4.2. You can see a 9-year follow-up scan with the audiogram at 9 years preserved, even though the tumor got to the lateral end of the fundus. But look at this response. The tumor is almost a ghost at this point. And I don't know why hearing is preserved in this case. Even though, the numbers are right, plan was good, we could easily have lost hearing here and said the same thing. So a lot of research still needs to be done. So right now in 2023, we can talk to a patient and say, you have a small tumor, you have excellent hearing. Observation leads to tumor growth and hearing loss in the majority of patients based upon the growth data and the hearing data over the next few years, but not absolute, of course. Hearing can go down even without much growth. You should be treated now and not observed. Are we ready to say this? Well, I don't think so. This might happen when a lot of reports from leading centers like ours and others show this. And it'll be interesting to see, because there's some work going on in radiomics and machine learning to look at the imaging-defined tumor biology, which might be able to predict growth patterns. And if that's the case, based upon, I hate the word AI, but let's call it augmented intelligence, our doctor's opinion may have a lesser role than a computer-based set of guidance. So this is sort of an ideal result. Small tumor away from the cochlea. You can see the space that exists, and I'm going to talk about that space in a minute. Here's a 6-month scan. The patient wanted to be treated. Tumor had grown a little bit beforehand, not a lot, obviously. Here's the 6-month losing contrast. Here's the 18-month. This is what it looks like at 18 months, the cochlea remains bright, and many people, and I'm sure you think about this as well, a bright cochlea, and I say is a healthy cochlea, and a darker cochlea usually correlates with hearing loss. We published on this years ago, and then a preserved audiogram. So it's sort of like the perfect thing. Tumor got smaller, the nerves are working, the cochlea looks healthy, the audiogram is good. But what's the long-term expectation for this? This is 18 months. Is this going to be preserved 5 years, 10 years? We will just have to see. So then people start thinking about cost, and some other recent work looking at resection and radiosurgery and observation, showing that surgery is a cost-effective approach here. And when you look at this data, radiosurgery is also more cost-effective than observation. I don't think patients think a lot about the value of cost-effectiveness. It's as opposed to the actual clinical things that matter tremendously to them, but it's something that is out there. Now, we all know that when we talk about the biologic effect of radiosurgery for any tumor that we do, and of course, tumors can expand before they shrink. I always tell patients that if you injure your knee today, tomorrow you expect your knee to be a little bigger. Your knee hasn't grown, but it's expanded, it's inflamed, it's a little swollen. You expect it. And that's the same thing with a tumor. We've purposefully and in a very precise way injured the tumor biologically. So in time, there could be this expansion, which then usually settles down. Some people use the word pseudo-progression. I don't really like the term, but it's been used in the literature. But here's one, for example, in a 29-year-old treated years and years ago at a dose, normally people are using 12.5, 12 to 13 gray, but here's a high dose years ago. And you can see at 2 years, you might think, oh, this didn't work, it's growing, but the patient's well, so they're observed. And look at the 17-year scan on that. So a recent paper from my old colleagues in Pittsburgh published this longitudinal volumetric response data from 200 patients managed over the last 7 years or so. And they saw this transient tumor volume increase of about 3 out of 10 patients over the first couple of years. And there was a failure rate with a persistent increase, and some of these had treatment, either resection or radiosurgery. And this expansion profile, which typically happens within the first couple of years, means that you have to be very patient with this. And when you see something, here's a tumor that was published, you can see the expansion, but you can see also what's happening to the tumor. Now, if the patient was symptomatic, this might lead to a resection. If the patient's not symptomatic, you could wait, and you can see what happened in this case with waiting over time and a massive regression in that case. Cystic tumors are another part of the interesting biology of these. Are they cystic because they're degenerating, or are they secretory in some way? These tend to respond best to radiosurgery, I think, because they're already degenerating. I think the process is already in place, but maybe the fluid is being trapped. This is why they also continue to expand. Here's a case in an 87-year-old woman, and here's that radiosurgery. Here is at 6 months, and here's at 14 months. Cyst is practically gone at this point, and that's a common expectation for a tumor cyst. Here's another one with multicystic changes in an 83-year-old. Obviously, most of these types of things are elderly patients. A scan like this in a younger person's going to have a resection. But here's a scan at 2 months, and here's a scan at 2 years. As the cysts go away, and the tumor probably sticks and scars on itself. So I mentioned the sort of the room left in the lateral canal as it relates to hearing, and this is our deep dive since I've been at NYU, and I arrived in 2012, looking at hearing outcomes over the last 10 years in patients who were suitable for extended follow-up. So 2013 to 2018, it was 353 patients, and we looked at the 74 who had high-grade hearing at the time of radiosurgery. And what really comes out of this is age is important, and this has been known before. Cochlear dose below 3.1 gray was even better than the 3 to 4 gray range. And this space that exists in the lateral canal, which allows the cochlea perhaps to get a lower dose below 3, was a significant predictor of hearing preservation. Now, it's interesting because if you see this, And of course, if you had a small tumor here, forget this part, but if you had a small tumor here and you saw that space, this patient now is sort of optimal for hearing preservation. But are you willing to recommend that? Or are you going to say, well, we're going to watch it because it's not very big? And of course, many of these will grow laterally and you will lose this. So it's something to think about in terms of decision-making based upon the anatomy location of the tumor. And we all know the matched cohort studies. I'll just show the NYU one from a few years ago. And tumor control rates were equal between resection and radiosurgery. That didn't matter long-term. Facial preservation was excellent in both groups. So, and I think that in experienced hands, facial nerve preservation is high. Radiosurgery does better within the spectrum of tumors. These are all tumors less than about 2.5 centimeters. Hearing is better early with radiosurgery, but probably by 5 years, it may be similar. We don't know that for sure yet, and I think the 5 to 10 year durability of hearing data as it comes out will be interesting. We'll just have to see on that. And of course, from a patient perspective, just taking hydrocephalus, infection, bleeding off the table is important now. But hydrocephalus can still occur with radiosurgery, and it happens about 1% of the time. We're looking at an analysis of this right now, probably from the persistent secretion of proteins into the spinal fluid that can lead to some degree of a communicating block. So that can still be an issue. And the studies that have been done matching resection to radiosurgery are interesting. I can tell you that at the quadrennial meeting in Bergen a couple of weeks ago, the Norwegian study comparing observation to radiosurgery was presented, and this information will come out in print soon. A lot of people have been waiting for that study. Quality of life is an issue, of course. Mayo has studied this. There's the PanQual Penn study. You published on this. This is a study years ago that looks at the greatest impact on patient satisfaction and quality of life. And it was balance more than hearing that had the greatest impact. And I think this is why from the Acoustic Neuroma Association, when the patients have been surveyed, they sort of list the top 4 things. And number 1 is stopping the tumor, facial preservation, balance, and 4th was hearing based upon their overall function and concerns looking back. When radiosurgery fails, it can be repeated, and this is sometimes appropriate in tumors that are still fairly small. It usually responds very well. So these are obviously cases that failed, and then to bring them back up into this profile. I usually say, people ask, why did it fail? And the usual reason is, well, your tumor didn't get enough radiation for your tumor, for whatever reason biologically. So it's an option. However, if someone is having symptoms that are bothersome, usually surgical resection is a preferred approach. I show this patient, and this is a patient that was seen at your place. He saw many people across the country. This was a tumor, and I just bring this up from a patient's perspective. He watched this tumor in 2015 on virtually every scan over the next 5 years or so. It got bigger, and so despite the growth, he didn't do anything about it. He was comfortable just watching, and his hearing continued to decline on every scan until he eventually said, okay, I'm ready to go, and I want to be treated. This was his hearing at the time of the procedure with a speech discrimination score of 30, and he wanted to, quote, preserve hearing, although functionally it was quite limited at this point. He said, I want this done in 3 sessions at 6 gray, and we did exactly what he wanted. So based upon his read of the literature, even though it's not exactly how we typically handle most patients, this is what he wanted. Here was his plan. And he did well. And you can see this is tracking him on the Gamma knife, because he doesn't have a frame on his head. He's being done with a mask. And he's moving less than 0.5 millimeter during the course of the treatment. So that's a very reliable patient who has that option. This paper was recently published looking at what to do following failure of either radiosurgery failures, resection failures. So resection after radiosurgery, the outcomes, resection after resection, radiosurgery after resection, and so on. And I think it's an interesting analysis of expectations following having to do something else. Let's move on to facial schwannomas, because I think we seem to be seeing more and more of them. and I'm sure perhaps you are as well. And I know sort of talked about this before and shared some patients together. A very challenging, complex problem, to be sure. This is the multi-center study put together through Dr. Lekovec and Dr. Slattery, Dr. Brackman, and colleagues at House, and together with data from ourselves and other institutions looking at the anatomic segment of the facial nerve. And a number of articles sort of came out of this multi-center study looking at different elements. And you can see this is 63 patients, so a number of centers to get that much information. And the conclusions are this is effective and spares facial nerve function in most patients. And there can be improvement afterwards, particularly if the labyrinthine section is involved. But all of these are sort of different, of course, and the anatomy is different, the volumes are different. When you see something like this, is this a radiosurgery case? Should it be partly resected? It really depends. This is a 28-year-old woman who had resection for what was presumed to be a vestibular schwannoma, and many of these cases where the facial nerve is stimulating everywhere, so the person closes and then sent to somebody. And so I treated this residual tumor, and you can see at 6 months there is internal change, probably cystic expansion, a lot, as you can see here. We watched this. Her facial function was normal. This was the 9-month scan as that collapsed, and then that completely resolved. This is what the 2-year scan looked like. And she is now out about 10 years, and facial nerve function was preserved, the entire time. Here's the 4-year scan on that same young woman. This is a recent patient, also seen at your place, who have been followed this tumor for a couple of years. And a complex shape. You can see the middle fossa component, and the tumor had serially grown. Young woman, about 32 years old, and hearing issues, good facial function, about sort of grade 2. And if you look at this most recent multi-center series, again, 42 patients, average age was 48, and most of them, solid like this. So here was her and her complex plan. And you can see this is a cochlea here in the middle, and we use this what are called lightning software. It's a special software that we have that allows us to do a very sophisticated computer-generated plan to have a lower dose here. It's not like this is being completely spared. Obviously, it's going to get some radiation, but it's getting a lower amount than the rest. So 31-year-old growing tumor, grade 2, a real challenge, but has done well so far in the first couple of years. This is post-radiosurgery and looking at House-Brackman grade. And you can see that for the most part, there have been patients who have remained within their grade. There was a few deteriorations, as you can see, but it's pretty uncommon. And most of the patients are keeping facial function. So I think that's the good news here. The issue is how big a tumor would we allow? When do we intervene? What about the role of bony decompression for growth? Should that even be done with radiosurgery? Should there be swelling? I mean, these are some of the unanswered questions. And if you look at this article going back 8 years, an interesting review that I like because it sort of looked at what was available, because there wasn't a lot available, and looking at papers with at least 2 years follow-up, you can see that the worsened facial nerve function is quite low. So I think that's, again, the good news. And the control rates were high. At least, this is not super long-term follow-up, but, it's telling us we have some opportunities here. And then the Mayo group did this sort of a systematic review comparing resection to radiosurgery for facial nerve schwannomas. And it's sort of becoming radiosurgery should be recommended to patients who require treatment. Surgery should be reserved for another indication, such as brainstem decompression. I think we're still gaining data on this interesting topic. And then, of course, other schwannomas that exist, and we'll show a few around the angle. Here's a trigeminal schwannoma, as you can see here, in a woman who presented with facial numbness. It's interesting that these schwannomas sort of behave differently. whereas the vestibular schwannoma tends to get dark on the inside, and about 70% of them regress. Trigeminal schwannoma, for some reason, maybe it's a blood supply issue, but these shrink the most. So you can see at 3 months what this looks like. Here was a 10-month scan, 2 years. Look at the 4-year scan. You're almost seeing like a normal, just thickened nerve now compared to what this used to look like here, and preservation of normal trigeminal function during that time. So a schwannoma is not necessarily, they're not all the same. Let's move on to glomus tumors. And I know you take care of a lot of patients with this problem, and increasingly we've seen more and more of these. In fact, we have shared some patients together with complex glomus tumors, and we can always go back. We always should go back and read the literature on these topics, and I show you this wonderful prior paper from House. So this was a multi-center study published a few years ago, 134 patients, again, about 58 years old. You can see 38% had undergone a resection. Some had prior fractionated radiation therapy, either Fish and Glasscock-Jackson grades here, and the average volume was about 5 cc's. A couple of big ones, but for the most part, these are not massive tumors. They need to be above the level, usually of about C2, to consider radiosurgery. And the inferior extent is often defined by how the jugular vein appearance changes versus the tumor itself. And fat suppression imaging, T2 contrast imaging usually can help sort this out well. And fortunately, a dose of in the range of 12 to 13 gray usually works. The control rate is quite high. And the issue then is tinnitus. And if that's the presentation symptom, what's the chance that that is improved? And for most patients, they preserve their function, but tinnitus is probably only improved in about half, which raises the issue about embolization or other devascularization approaches to improve patient symptoms. So sometimes, multimodality therapy is needed. Here's one, for example, 10 years of right hearing loss, has some 11th nerve symptoms. You can see that shoulder is a little lower from an 11th nerve issue. There's atrophy on the right side of the tongue, a large tumor here, you can see. And the control rate for glomus tumors has been high, as I mentioned. So according to Glasscock-Jackson grade, one can stratify the expectations out a little bit more. And initial versus salvage, patients with no prior resections tend to do well. These tend to be more bad actors in patients who have had a prior resection, usually meaning a larger tumor. So let's take a little tour for some more around the CP angle as well. This is a tumor that might be seen by neuro-ophthalmology colleagues. There's a little bump there, and near the tentorium, lateral surface of the midbrain, and presents with a diplopia presentation. And this is a fourth nerve tumor, a trochlear nerve schwannoma. How do we know? It can be difficult. And I think we always have to think about other pathologies. Is this sarcoidosis? Is this Rosai-Dorfman disease? Could it be a lymphoma? Could it be something, a granulomatous process, something else, a hemangioma? We all know the differential diagnosis of tumors in this area. And so this patient had been watched. The patient had been put on a course of corticosteroids to see if that made it go away, as an inflammatory mass might resolve, but it did not. Expanded, and so a radiosurgery plan was provided. And he had multiple eye muscle surgeries, which is difficult for fourth nerve rehabilitation, but he was able to get to good vision with straight ahead gaze, and you can see the tumor barely visible anymore past 3 years after a radiosurgery. So I think this is becoming the thing to do for smaller oculomotor region schwannomas. So here's one, and I asked the question, we talked about facial nerve schwannomas, but here's a general surgery resident who is managed at our place, and the thought was, looks like a vestibular schwannoma. He had sudden left hearing loss, which improved with steroids, had some tinnitus. He had a resection here, but the tumor completely stimulated everywhere, so the surgery was stopped with the diagnosis of a facial nerve schwannoma made. But when he woke up, hearing was lost just from the exposure. And then I ended up doing radiosurgery on him anyway. We had met with him before, but he wanted to be resected and has done well after that. This was the radiosurgery plan. And this is 6.5 years later. Here's what it looks like now with a regression and preservation of normal facial nerve function, house grade 1 at 6.5 years since a surgeon director in the Southern United States. Here's another one that one might see in clinic, and the patient presents with syncope, and imaging shows a mass down near the course of the hypoglossal canal into the skull base. And the diagnosis is made again with observation and persistence of this lesion of a 12th nerve schwannoma. Is it? Well, we didn't biopsy it. And this raises the issue of management of tumors without histologic confirmation. And but based on our group with our radiologists, we thought this was a hypoglossal schwannoma. And this is the same plan. You see the same dose we would do for a vestibular schwannoma. And you can see the loss of contrast in this tumor that occurred, but she got a hypoglossal deficit. So she had some slurred speech. She had left tongue weakness, some tongue atrophy from treatment of a motor nerve there, which is not unexpected, but not necessarily guaranteed. And the dysarthria resolved as her tongue function became adapted to, but hypoglossal schwannoma. Lower, just at the lower part of the CP angle, what about jugular foramen schwannomas? And of course, this brings into play other cranial nerves and other functional issues, voice, swallowing, tongue, shoulder, so on. So this is a 23-year-old woman who had a sizable tumor here. The intracranial part had been resected. This was left. And at the time of her care, based upon her age, the thinking at the time was that, oh, she's young. She's too young to be radiated, so let's just observe this. Well, what happened within 2 years is that this whole thing grew, and it more than doubled in size. And so the issue was resection again or radiosurgery. So she underwent radiosurgery. You can see the dose was 11.5 gray. She developed a transient 11th nerve dysfunction. She said, I couldn't elevate my shoulder at 3 months. And then that resolved about 3 months later. And then this was the tumor at over time, and it hasn't required any further treatment now at 9 years. Is this a jugular, a glomus jugulare? You know, how do we know? Well, I think we can be confident from an imaging perspective that it is, and with the presentation prior partial resection, as I mentioned, these are optimal cases for radiosurgery or in some patients of large fractionated radiation. But surgical removal, devascularization, embolization, of course, remain excellent choices. Fortunately, pulsatile tinnitus resolved in this patient and comfortable again. I'm going to show you this one with, this is a foramen magnum meningioma, so the inferior aspect of the skull base. And this tumor had been watched over 10 years, had shown slow progressive growth. Here's the mass, here's the vertebral artery. As you can see here, here's the coronal view, medulla. And there's publications on this with a high degree of safety in radiosurgery at the foramen magnum for meningiomas. Here was the plan, standard dose for a meningioma, as you can see. And then I get a call a few months later that the patient was having weakness of the contralateral side. And you can see on the MRI that there was some edema beside the tumor in the medulla. And you can see that. You can see that here. Really should be very unexpected. We typically do not see this much with meningiomas. You sometimes do see it with vestibular schwannomas indenting the peduncle. And she required corticosteroids. And 9 months later, that largely resolved, and her symptoms had completely resolved. But you know, this is high rent real estate. It's important critical function around the vasculature of the skull base. And things like this can be seen, and fortunately, the biologic response can happen. I show you this case as an interesting case of vascularity, and if you think of a glomus tumor, you know, what is happening to it? Is radiation scarring it and reducing its vascularity? This is an arteriovenous malformation of the brainstem, a large one. It had been found in the pons after an episode of syncope and observed, because nobody wanted to tackle this big thing filling most of the brainstem. But 3 years later, he had a hemorrhage, and you can see the blood in the ventricular system. This caused diplopia and ataxia He made an excellent recovery, but these symptoms persist even now years later. We did tractography, and we could see that his motor fibers were going right down into where this brainstem mass is. This is the tract. Here's the brainstem AVM and the tract. And here's what the AVM looks like, filling most of the pons. So it's poking into the CP angle on its lateral edge. And look at the arteriogram showing this massive AVM of the brainstem. And it wasn't even clear what to do with this even after a prior hemorrhage. I talked to a lot of people in the country about him. And we ended up giving him a very low dose of radiation. Normally 16 gray is sort of a lower limit for an AVM. And I decided to give him 12 gray and perhaps bring him back in a year and treat him. Here's the plan for this thing. And so we watched, and he did well. He didn't bleed again. And the imaging over time, here's the 1-year scan. It looked good. It was getting smaller. So I decided not to do anything with him. And we watched him. And at 3 years, here's an angiogram. You remember this was all AVM before, and now we hardly see anything. There was a little bit of flow left. And here was the 4-year scan. And at 5 years, we ended up completing that. So sort of finish, when I think of the role of radiosurgery around the posterior fossa, the CP angle, and the skull base, sort of think of seven items to consider when a care plan is being developed. Number one is, that tumor on imaging may not be what you think it is. And I think we always have to remember the differential diagnosis of enhancing extra axial basal lesions, which are not always, they could be schwannoma, meningioma, different grades of meningioma, other tumors. And of course, they can have their even different biologies. It may not always be a slow growing, indolent process. The second one is that just because it's good for resection doesn't mean, it's not good for resection, doesn't mean it's good for radiosurgery. So we all see patients, well, geez, it's a big one, but the patient has has real medical comorbidities. I don't want to operate on that. Let's do radiosurgery for that. But it might not be a good radiosurgery case either, based upon it may already have brainstem edema, for example. So there's already signs that the vascular integrity of the tissue is not good. And if you radiate that, you should expect more swelling. Maybe that needs a resection either way. Number 3 is you have to know your anatomy and even the distorted anatomy, because these tumors will change things, and high resolution imaging is the key. And if you have trouble, get other people to help you look at the scans at the same time. There's rules on cranial nerve tolerance. As I showed you many tumors with low dose radiosurgery, which means the nerve should tolerate them. But as I showed you, they didn't always tolerate them. The 12th nerve did get a deficit of the tongue. So that can happen. And so there are rules, but they're not sacred. And remember what the goal of the procedure is. Remember, there may not be another option. So if surgery is not a choice for this person, it's already been observed, that may argue for a higher dose of radiation. It has to work, or it has to be more durable, or not, or maybe there's other options available. Age is often irrelevant for radiosurgery, but younger patients clearly do better when it comes to cranial nerve tolerance, parenchymal tolerance to radiation. So risks can be higher in a less healthy patient. And of course, we all know that this is a multidisciplinary field, and never feel afraid to ask for help. And all of these patients are cared for by a disciplined team, like your center, our center, and the top centers of the world.